Next is Dr. Shalinder.
So my case is of primary PCI, a 62-year-old male. Next slide. This is one 61-year-old male, type 2 diabetic, with a history of chest pain with profuse sweating from 1 hour. And on ECG, it was a posterior wall MI, posterior lateral wall MI. And I got the call from the early in the emergency. Saturation was around 85, 86%, and BP was around 70 by 50 systolic BP. On echo, we see that it was EF of 20 to 25% with movement of RC only and no movement of LED and L6. And patient had about moderate to severe MR. So we decided to took the patient for angiography. And this was the ECG of the patient. Last slide, please. This was the ECG of the patient. It's showing ST elevation in 5, 6 with ST depression in V1, V2, V3 with the BPCs present. So patient was very sick. So we decided to take the patient for CAG. Otherwise, we will lose the patient. Next slide, please. So next slide. Next slide. So we next slide. This play the slide. So this was the RCA shot. It was a totally normal RCA. And left next Sagarji. Next shot. Next. So this was the left system. I think the whole left system is gone. Left main is around 95% diseased with around TIMI1 flow in LED, L6, and patient was in very bad condition. So we decided to put a IABP and to do the PTCA. Next. So we did IABP immediately. We did a IBP from the right route, then from which we have done the angio, and from the left we decided to do the PTCA. So we wire the left main to LED, and we see that there is only severe thrombus in LED, L6, and left main. Next slide. Next one. So we dilated the left main and LED ostia with around 2.75 balloon, and then we put the stent. Next. We did a thrombosuction from left main to LED, and this was around 3.5 to 38 stent that we put from left main to LED, and we dilate the stent. Next. Next slide. Then we do the left main port with 4 into this 10 balloon, and patient was on IABP. This next shot. So this was the next 2 shots. We have taken only the few shots because the patient was very sick. He was having saturation of 85, 86% on IABP, and augmented BP was around 90 by 60. So this was around good flow in LED. Well, ostia disease in L6 present, but we left it as such. So and then patient was shifted to ICU. Patient was on norepi, epi on 15 ml, both norepi and epi, and on IABP. And also we have started on L6 infusion. So then patient was off the IABP after 3 days with inotropes reduced to around 4 to 5 ml norepi and epi. And then we decided to recheck the angio after 3 days. Next shot. This was the ECG. This was post PTC ECG. So this is showing a QRBB type pattern with the ST changes have slightly settled down. And next, Sagarji, next. So please play it. Please play it, Sagar. Play this slide, please. So this was the check angio. Please play it. We did on after 3 days. This was the check angio, and it is showing normal flow in LED and L6. So next. So this was the last. After 3 days we did the check angio, and it was showing the normal flow in LED L6. Patient was off IABP, but on echo we see that it was severe. Patient was having severe MR. So we shift the patient to room. Then after 12 days, patient in the hospital, during the hospital, he had severe pulmonary edema with septicemia. And that is after 12 days, we lost the patient. But once we have seen that we were able to shift the patient from hard command to the room. but it was the severe MR which was the causing the trouble again and again. So we lost the patient because of MR. He was having severe pulmonary edema, then reshifted to heart command. Then after 2 days, we were unable to save the patient. Thank you, sir.
Thanks, Shalinder. Again, this was a chip case, a complex one, and thanks for giving us a very true picture that ultimately patients succumb to MR, and this is not again unusual. We do a lot of effort in the revascularizing, and then the LV dysfunction, and if it is complicated by mechanical complication or severe MR because of some reason or the other, these patients then really do not do well. So I had one case like this, and fortunately we are a clip center. So the patient was not coming out of IBP, not coming out of BiPAP. He was in AKI post plasty, post primary, old patient, and on sixth or seventh day we kept on waiting that it may improve. Didn't improve, and then after a good discussion with the family, we clipped that MR. I did a mitra clip to that MR, and that was a salvageable point that saved the patient. So yes, this is one point which we should always consider. Because their LV is now gone into a bad state. LV EDPs are very high, PA pressures are high, and if complicated by MR, they will have a poor picture. But you tried your best. I think even doing a left main to LED plasty in such situations is not without a hormonal surge for operator also. So thank
Yeah.
you, Shalinder. It was a good case. Any
We
comments? Gautam is here.
So,
Rupesh.
how was the RCA?
RC was normal. RC was normal.
Okay. Well, I was wondering you why MR because Circ also has a good flow, though there's an
No,
oscillation in the
initially it
Initially, sir,
was
we did not
there
have
was no flow. I mean,
all the
just
left system is
Yes,
gone. Only
initially there
one
was no flow.
SC.
Yes, but
so
I was wondering
he
how.
he had an infarct in both LCX and LAD territory,
Exactly.
which probably led to
Led
uh,
to the MR rupture.
In all points to Shailinda for doing it was a phenomenal job. Ultimately, the patient passed, but then this happens to all of us. It was wonderfully done. Like all points to you. All, unfortunately, we also like in such a situation as I mean, a lot of time the clips is the only option. Unfortunately, it is slightly costly as of yet, but uh, all points to you. I think we did all we could.
only one thing which I like to add, Shalinder. If there is a severe MR with LV dysfunction, which is acute onset, I think I mean, this is retrospectively in your case, one should hang on with the IBP for a longer time,
Okay. Okay.
maybe a week, it tends to settle down with lot of diuretic. Keep on giving diuretics, LVEDPs come down. It is just a small uh, barrier. You have to come down before the vicious cycle sets in. If you break that barrier, maybe the hemodynamics will improve to this category that patient survives. So without clip, I think this is the only thing which comes to our mind, that
IBP
you
is
know,
perfect.
keep the
Yes.
ICU stay, more critical care, and IBP for at least a week, 8, 9 days.
Okay. Thank you, sir. Thank you.
Okay, thanks, Shalinder.
Sir,
Yeah.
one question, sir. We many a times we have patients with lateral wall MIs or inferior wall MIs when we do an angio, 24 hours post, presentation. They come to us at times, late. Circs are OMs are included in major OMs, and they have moderate MRs or severe MRs. At times you open those vessels thinking that reperfusion may help us. With the contractility, the MRs may improve. But I've seen many patients, probably 40-50% are even done within 24 hours or 36 hours. They usually don't. MR, it becomes relentless. Sir. What's your take on that? Should we open? Should we not open? Because we lost two patients. Once we opened in MR, they had a pre-wall rupture. One had a papillary muscle, rupture. So it's a very OM it becomes very nasty after 24 hours.
No, I think RCA or CIRC, they are more vulnerable to give MRs. If there is acute MR, which
Right.
is now
Yeah.
there, which is severe in this setting of acute MI, it's going to be nasty affair.
Yeah.
If it doesn't improve on revascularization, if it doesn't improve with the afterload unloading, we decrease the afterload with IBP or
Yeah.
dobutamines or whatever, then it's going to be a problem, acute MRs. And now, if the patient reaches a spot in about 10 to 2 weeks' time where he starts tolerating this MR,
No.
Only then the survival would come. If he's still not tolerating, the LA pressures are so high and it's leading to pulmonary edema. As soon as you decrease these afterload decreasing modalities, then patient will have a tough time. So mortality in this situation with MI, acute MR, and especially if the LV has gone down lesser than 30%. If the LV is 45%,
No.
still the cardiac output will be maintained and MR will be tolerated. But if the LV has also gone down and there's a severe MR and it is acute, I mean, beware. This is a very tough subset.
Yeah. And your take on phosphodiesterase, IV midlinone, amrinone, sir, in acute
We
MI with
use
severe
that.
MI?
We use
Yes.
that in acute setting. That's the reason I'm saying patient has
Yeah.
to be in ICU for a week at least.
Right.
And we do one thing. IBP will reduce the MR little bit. We switch off the IBP for half an hour and watch.
And I'll see.
The PA pressures, where are PA pressures going, whether MR is increasing, whether tachycardia is happening, and if that is happening, or X-ray. I do one thing before taking out IBP, we switch off the IBP for half an hour, 1 hour, and then do the X-ray. If X-ray is going bad, we don't take out the IBP for two more days, more diurese. So those things may help, but at times these
Yeah.
patients may not really
You
help.
may
But
know.
these are the things which would help. And
Problem is
Right.
that
obviously, in
these
such
patients,
situations, now Rupesh has pointed out that clip is very costly. The good thing is happening, Rupesh. 14th,
My,
15th is a my clip.
Sir, are
my
you
clip,
traveling
my
to
clip.
Vapi?
I'm coming. I'm coming.
I'll be there, sir. Let's
I
meet
have
there, sir.
I have put my off.
Yes, I was coming, sir, but I'm not coming. I'm on leave, sir. I won't be able to join you.
Uh,
My clip launch है, sir. हाँ जी, जी.
So I have
Right.
used my clip in 5, 6 patients.
Sir,
So they have given us on
Okay.
compassionate grounds initially in last 2 months. It's a
sir,
good clip. There are still certain points which need to be improved that we're discussing with Meryl. But my clip 5, 6 patient total clip I have used around 40, 50 patients. So I think now with the my clip on, the cost is coming down to 21, 22. So 33
Okay.
से 22 हो जाएगा, and with due course in a year now Abbott will also decrease the price. They
Yeah.
are keeping the price around 18 lakhs for the clip. So the launch is there, but at least more numbers could be done with my clip there.